Thanks everybody for coming here and making time. We have a really fantastic session for tonight. We're lucky to be joined by members from the AHNS skull base section and the ARS. So you might recognize some of your prior co-residents on the call today. The ARS fellows have been invited, so hopefully some of them will be here. Give everybody a warm welcome, including our esteemed panelists and our moderator for today. So today we're really lucky. We're lucky to be joined by Dr. Shirley Su, who's chair of the AHNS Skull Base Surgery Section and professor in the Department of Head and Neck Surgery at MD Anderson. She'll be moderating today. Welcome, Shirley. Dr. Mark Cohen, co-chair of the Clinical Care Committee for the AHNS Skull Base Section and director of the Pituitary and Skull Base Tumor Center at Memorial Sloan Kettering. Thanks for being here. His fellow is Daniel Schofield, who will be presenting. Dr. Marlene Wang, Vice Chair of the AHNS Skull Base Surgery Section and Professor in the Department of Head and Neck Surgery at UCLA and co-director of their Skull Base program with her fellow Rory Lubner. And Dr. Edward Kwan, Professor in the Department of Head and Neck Surgery at UC Irvine and co-director of their Skull Base program. His fellow is unavailable, so he'll be presenting today. Thanks for doing that. We're also really fortunate to be also joined by our multidisciplinary expert discussants today, Dr. Neil Cave, a medical oncologist from MD Anderson, and Sean McBride, radiation oncology from Memorial Sloan Kettering. Thanks so much for being here today. And a special thanks to Matthew Geltzeiler for setting up having both the fellow groups on today. And I'd love to hand things off to Dr. Su for the remainder of the session. Thanks everyone for being here.
Thank you so much for that really great introduction, and thank you so much for having us, the skull-based section of AHNS and ARS, on this virtual tumor board. It's always a pleasure to be here. So we're going to do 3 cases today, and the first case is from our colleagues in Memorial Sloan Kettering, Dr. Daniel Schofield and Dr. Mark Cohen. Dr. Schofield, you can share your slides.
All right. Great, thank you.
So am I just supposed to interrupt him and correct him like in the real world, or am I supposed to be kind and let him speak and sort of go about his business normally?
I would just remind you there are a lot of fellows on this course, so you may want to think about it.
I just preface this case. This is a challenging case that I'm bringing just for educational purposes and for knowledge and for me to learn as well. So it's not one of those like, we did everything awesome and here's our cool results.
Perfect. Okay, so
Right.
right. So we'll let you get started, and then we'll perhaps you can add questions to the panelists, and I can add some questions additionally as well. Okay.
Thanks. Can you see my slides?
Yes, we can.
Great. Dr. Cohen, real world is good. So just thank you, Dr. Barber, Dr. Su, JJ, and the rest of the organisers for inviting us to present a case. As Dr. Cohen's mentioned, this is a really challenging case of recurrent disease with interesting questions about neoadjuvant treatment and subsequent adjuvant treatment after a large resection. So this is a 61-year-old gentleman who had a partial maxillectomy and neck dissection at an outside hospital in 2021. This was for nasal cavity P16 positive SCC. He then underwent adjuvant CRT with 3 cycles of cisplatin. He was followed closely for the next 4 years until he was seen at follow-up with increased infraorbital swelling, which was concerning for recurrence, and the biopsy at the outside centre was positive for recurrent SCC. His past medical history and social history included a previous DVT, alcohol dependence, but he's a non-smoker. On exam, he had no palpable lymphadenopathy. As you can see in the first and second photographs here, he had induration of his left cheek and medial canthus. And if you looking closely, he also had a small fungating tumor emanating from his medial canthus. Examination with flexible nasendoscopy was limited due to extensive crusting. So the first questions here, what imaging studies are required? And also, does anyone see any indication for a repeat biopsy on presentation to your tertiary center?
Okay. I'm not sure here whether the fellows are able to comment or perhaps we should pose this question to uh, JJ. Dr. Baba, can you tell us, are we supposed to be asking the fellows here or?
Yeah, usually you just ask the person that's presenting or ask one of the expert discussants, but in this case, since it's multidisciplinary, it's up to you.
Okay, well,
I can
so
monitor the chat for you if you'd like.
yeah, thank you so much. So what imaging studies are needed and the need for repeat biopsy? Would Dr. Kwan like to take this question?
Yeah, absolutely. So definitely highly suspicious for additional involvement beyond the original field. So I would be curious to try to restage the patient. I would recommend usually doing a CT sinus for operative planning. I do favor an MRI maxillofacial with and without contrast to look at the soft tissue in the orbit more detail, and then also potentially consider a PET CT just to see if there's any also distant or regional disease that can be detected. That's what I would start with.
Right, okay.
Right.
And would you do a biopsy?
I think you have an outside hospital biopsy that's confirmatory at this point. So, depending on the imaging, if it's pretty contiguous or highly suspicious within the local field, I don't think it's necessary to repeat it. I would certainly ask for the slides for a secondary review, though.
Okay, sure. Anyone else would like to add anything here? Dr. Kavi, Dr. McBride, Dr. Wan?
Yeah, I agree with reviewing the pathology slides from the outside hospital just to confirm. But it most likely is the squamous cell carcinoma, and I agree that imaging I would get both a CT scan and an MRI because you've got likely bony involvement and soft tissue disease.
Perfect. Okay.
Great.
I do want to ask, there's been a 5-year, I guess, disease-free interval. So, did you all feel that this was definitely a recurrent squame of the sinonasal cavity, P16 positive? And, was this HPV positive? If it was, then, what are the likelihood that a highly sensitive chemo and radiation sensitive tumor would recur at this point? And secondly, was there any consideration that this may be a cutaneous squame?
Yeah, thanks. I think after reviewing the operative report from the outside surgeon and then the subsequent imaging, which I'll show, it was very suggestive of a recurrent tumor.
Okay.
And
Proceed.
yeah, we did those.
Both the so for Dr. Su, the initial surgical pathology was P16 positive, and the biopsy, and that's not definitive, and the biopsy was also P16 positive on the outside.
Okay.
So not definitive, but highly suggestive.
Thanks. And yeah, as recommended by our expert panel, we did all of those imaging studies. So CT sinus, looking for bony involvement, an MRI scan, which you can see in the first image there. Sorry, we've only got one slice, but you can see an enhancing infiltrative soft tissue mass from a nasolabial fold invading into the orbit, the medial canthus, and abutting the inferior medial rectus muscles. We also undertook a PET CT, which showed a hypermetabolic uptake along the nasal bridge with underlying erosion and extension into the orbit. There was no distant disease. There were some equivocal lymph nodes in level 2 of the neck.
Yeah.
And so then really the question is what to do next. So whether to proceed with upfront surgery, and if that's the case, what operation, whether there's any indication for neoadjuvant treatment in this recurrent disease, and if so, what agents and why, or is this a palliative case? Or is there an option for, at this point, reirradiation with concurrent chemotherapy? So just interested to hear what the approach would be at other people's centers before
So
we go into.
before we get there, so one of the things that I was sort of getting at before is the CPS score. CPS was 7.
Yeah, CPS 7, yeah.
CPS was 7. Um, and the other question that I have is, prior to choosing what we're doing here, are you guys at your various centers getting sequencing these tumors in the recurrent setting? So those are sort of the two of the other points. I see a hand up there by Dr. Magnuson.
Thanks, Mark. There was a statement or a question asked about whether this was cutaneous in origin or sinonasal in origin. And unless I didn't follow things correctly, you had mentioned that this was P16 positive. Were you saying because it's P16 positive, it's sinonasal origin, like we see in oropharynx? Because you can see P16
Sure.
positive in
Yeah.
cutaneous.
Yeah,
And
so
my question is, was there an HPV-ish performed?
it's a great question. The initial pre-treatment scans from 2020 were in the nose, intranasal, a nasal cavity cancer with extension into the maxilla. That was P16 positive. But you are very, very correct. P16 positivity does not rule out skin cancer. But we did not do any further workup based on the primary presentation.
Thank you.
Yeah, thank you. I think that's a really great
Great point.
question. And I know we have some systemic therapy and radiation questions. So um, I I want to ask, okay, so maybe we can talk about the chemotherapy first, that um, in the non-recurrent setting, in primary tumors, we give neoadjuvant chemotherapy for organ preservation to downgrade tumors. So my first question would be to Dr. Kavi. Would a HPV status in sinonasal cancer change the way you view, um, would it change your management if this was a not, non, like a primary tumor that hadn't been radiated before? And then for this patient, given they've had radiation already, and the definitive, and the induction chemotherapy followed by radiation therapy pathway is a little more tricky. How do you feel neoadjuvant systemic therapy, and what agents and why?
Yeah, I think this is a great question. I think going back to Mark's question about would I do any other additional, diagnostic studies, I agree with everybody that dual testing for HPV would also be worthwhile. I think if we're going to go down a curative intent route, other things that we would consider as maybe an extrapolation from the oropharyngeal space is like a NavDX type approach where you could do it pre and post just as a supplementary tool. With regards to the question about NGS, I'll just quickly address that. It really depends on where you are. I'm certainly not so conceited as to say that that's always going to guide me with regards to the next steps. I think that's going to be for future clinical trials, or if you have access to clinical trials. I don't know if that necessarily would guide me in the immediate term. I think we do order it commonly, but I don't know if it's going to guide me in the immediate term. With regards to systemic therapy, historical regimens that we would have used here would have been like TPF, taxane 5-FU, and platinum, or PCC, which is platinum, taxane, and cetuximab. In general, in the sinonasal space, I think either are fine. We know from now the oropharyngeal population that HPV positive cancers seem to respond less to EGFR inhibitors like cetuximab than HPV unrelated cancer. So I do think knowing if this is HPV positive or not may guide the choice a little bit between those two regimens. Although I will say in this particular patient, more and more, again, really almost as an extrapolation from the palliative intent setting, we've used what I'd almost call palliative intent systemic therapy with chemotherapy and immunotherapy with the option of surgical consolidation. In this instance, it almost feels like we're giving conversion therapy where we're trying to reduce the volume of disease to then proceed with a salvage surgery that hopefully comes with reduced morbidity and improved prognosis. In that instance, I would use platinum, either 5-FU or taxane, although I use commonly taxanes, and then Keytruda or pembrolizumab.
Well put. Very well put.
And I think the question here comes then to reirradiation. I think Dr. McBride is on the line. How do you see reirradiation in this setting with or without chemo? Uh, in the salvage setting, do you do protons?
Yeah, I mean, I think the, obviously the first question is to look at the prior radiation fields and try to understand the proximity of the recurrence of the prior radiation fields. If it's directly overlapping, obviously your assessment of the morbidity of reirradiation is going to be heightened. It's a fair you have a fair bit of time between the initial prior radiation and when we're contemplating doing reirradiation, so there is probably some tissue healing here. I think it's a decidedly secondary option, in terms of the curative intent treatment. I think, what you could do in this situation, I think what we sometimes do is the same reason we do neoadjuvant before surgery. We would consider neoadjuvant to be beneficial prior to radiation because it would conceivably reduce the amount of gross tumor volume that you're treating and could reduce the morbidity of treatment. But whether we would do protons, I mean, here, I'd want to see more of the imaging. I think protons could potentially be more sparing of the optic nerve. And I think it's a serious consideration here. It tends to be our tendency to do protons in the reirradiation setting and for skull-based recurrences. So certainly that's something that would be top of mind if we were going to go a radiation-based route. But I would be a little bit hesitant about that.
Okay, great. I guess before we see what surgery did, let's see what surgery did.
Yeah, and just before the surgery, we on DMT review, the team decided for induction with Taxol, carboplatinum, and Pembro. Unfortunately, there was a limited response after the third cycle, so the decision was made to change to cetuximab and Pembro to try and get a reasonable response. However, after 6 cycles, there had been no significant change on imaging or on clinical exam. So we proceeded to surgery.
So just to take a step back, so just like Dr. Akave had said, we kind of did this with the hopes of maybe we'd be really lucky, like, the Chinese data and get a complete response with incorporating that immunotherapy. But really the purpose was to pile on systemic therapy to maybe make the surgery less radical, realizing that it would be a pretty aggressive operation to begin with. And we really accomplished neither of those objectives.
Yeah.
So we did proceed to surgery.
Yeah, so a radical operation, as mentioned. You can see in the first image our incision. We undertook a radical maxillectomy with orbital exenteration, resection of the hard palate, partial rhinectomy, and dissection and resection of the PPF and infratemporal fossa, left total ethmoidectomy, neck dissection, and the patient had free flap reconstruction. The findings with an ALT free flap, which you can see in the fourth image there. So just a soft tissue reconstruction. The findings at surgery were tumor involving the medial and inferior orbit, involvement of the ethmoid air cells up to but not involving the skull base.
So go back a second. And Shirley, I don't mean to take over for you, but a question for, I guess, Dr. Barber or Dr. Magnuson or other folks that are around here that specialize in reconstruction. What is your take on the reconstruction options here in the post-failed CRT setting with a tremendous amount of facial subunits, including the orbit removed, with the potential to need reirradiation down the road depending on pathology? What are our reconstructive options, and what would you guys have done?
Go ahead, Brittany. I can tell you what I will do. So because I have this exact patient, but on the right side.
Yeah, I have this.
Is it different on the right side?
It is. No, it's not
I
different.
have this patient next Tuesday. Yeah, so I think I'm sure Scott will probably agree with some of these things, maybe have different approaches, but I think certainly you hit on a bunch of things, which is that you need bulk because the patient's going to be re-irradiated. So you certainly did that. You put some muscle in there, which is going to protect the skull base, which is going to protect the, other adjacent structures. So I think that's fantastic. I think there a little bit of this ends patients get a prosthesis or not, which they're not sure about. You talk to them about it in the pre-op setting. It's always a discussion that needs to result in putting in more bulk rather than less because you can always debulk rather than have that discussion afterwards. You've put in something too thin. And then I think also probably an incredibly important thing, and it looks like you addressed this during the case, is that these flaps are heavy and gravity works against you and swelling works against you. And so you have to take that into account when you're reconstructing. They love to pull away from the bone, the frontal bone and the supraorbital region. And so it looks like you underset this really well, which is, I think, pretty important because it's really difficult to have to address exposed bone in this setting, especially in a re-irradiated setting. So it looks like you hit on all those things. You certainly appropriately overbulked, anticipating this was going to shrink down a lot to protect that bone and to protect the skull base.
So, Mark, we discussed ALT versus scapula, and we went with ALT because we wanted that soft tissue bulk for the reasons that Brittany just said. We didn't feel that the bone was going to help with the facial projection. Um, I just want to say um, it's a completely different discussion than today, but it's a very exciting discussion. So this was during the holidays, and so we couldn't get the patient on the schedule. So he also underwent neoadjuvant treatment with carboplatin, paclitaxel, and pembro, and the pathology came back no viable tumor.
Wow.
So he had a complete pathologic response to neoadjuvant treatment.
Awesome.
And and yet I removed his eye like you did. So it's one of those thinking back, what are we going to do next in the world of immunotherapy? And
Wow.
that's why I asked about the HPV-ish and whether it was truly HPV or if it was cutaneous. So but this case we did exactly what you did. Orbital exoneration, maxillectomy, ALT free flap.
Scott, can I ask, just not to interrupt, but in your case, was it the feeling still that it was paranasal sinus, or was there a suspicion now in hindsight that that might have been cutaneous? I will say that at least at our institution, one of the ways that we can guide this question comes up all the time. How do we sort of differentiate between cutaneous and mucosal? The way I've always done that, and I think the easiest way to do it is if you happen to order NGS, you look at tumor mutation burden as a guide. If tumor mutation burden is less than 10 mutations per megabase, it basically is mucosal. If it's more than 10 mutations per megabase, you've basically anchored it as cutaneous. And that's going to predict for a really good responsiveness to immunotherapy independent of PD-L1.
Yeah, good question. We didn't do NGS. Again, this was a holiday issue. People are going away. We need something to buy time. But looking at this patient that Mark is presenting, this the imaging of this patient, it looked more cutaneous than it looked sinonasal, just in terms of the recurrence. Now, that doesn't mean that it was originally cutaneous, but to answer your question directly, it was too difficult to say because there was definitely skin involvement as well as extension into the maxillary sinus and into the inferior orbit.
I think one of the things, so perhaps we can take a few minutes to discuss how we want to restage after chemotherapy, immunotherapy. I feel that, in the chemotherapy, in the post-induction chemotherapy setting, even if you see a great response or MRI or maybe even PET, you can then leave the disease alone. But in the immunotherapy setting, it's a lot harder to make that call of, what is there residual disease? You know, um, if it's a complete response, how do you treat that? So I guess there's two questions here. First of all, how would the panelists image after chemoimmunotherapy to determine the extent of the disease. And secondly, if you were to have a substantial response to chemotherapy and immunotherapy, would you modify your surgery to suit? So like a adapted, right?
Yeah.
Response adapted surgery, which is what HN14 is doing right now. So I'm going to ask Mark that.
Yeah, I think the second question is a more compelling question for me. Obviously everyone talks about and all the fellows know about 689. But we don't know about 689, and what one of my partners is really focused on is surgery in that 689 cohort. What was done? How much was it de-escalated? How much wasn't? And we don't have any concept of what. Alex, I'm talking here. Thanks. We don't really have any concept of what 689 has done. And in contrast to the good old days of pre-immunotherapy, I think everyone kind of thought when they were doing a post neoadjuvant surgery that you probably should stay to the original margins because there's probably these islands of cells, which we don't really know if that's true in the immunotherapy era. So I think what's really important is kind of looking forward and actually studying this prospectively and seeing what we do with our surgeries and seeing what the margins look like at those surgeries prospectively to see what we can get away with. I think the early compelling data is that you can probably de-escalate your surgery and spare that eye and spare that skull base, and the patient probably does just as well, but we just don't have the data to support that yet. So I think that's the big question in this exciting immunotherapy issue is like, what functionally are we doing to patients and can we get away with it?
Right. And I think this would be a great question here for Dr. McBride is that let's say the patient had a complete response and Dr. Cohen went in there and did a bunch of biopsies on the skin endonasally, perhaps a cotal log, did a whole bunch of biopsies in the area. And he said, okay, look, he biopsied the periorbita, took down some lamina. There was nothing there. Would that actually change your radiation paradigm if this was chemotherapy with IO versus chemo alone?
You mean if he's done that as part of taking additional biopsies as part of the primary resection?
Exactly. Would you be
Yeah,
comfortable, like, let's say he just did
I
biopsy,
think
mapped
yeah. I
UV
mean
saturation, if there
that's
was a
a that's
complete
a great
response?
yeah that's a great question, and I think where I think if this was P16 HPV RNA-ish positive, obviously we're always very hesitant to reirradiate, especially if this is an in-field recurrence, especially in this area. And I think traditionally we look at pathologic factors to make a determination. Now, how do you modify your assessment of the pathologic factors in response to neoadjuvant chemo or neoadjuvant chemo IO? I think we don't know is the bottom line. I think we are more likely to hold off on adjuvant radiation if we've had a complete response to an IO-based regimen because of our assumption of that the durability is more substantial than it would be with chemo alone. I think where we're going to be in the very near term is for these P16 HPV RNA-ish malignancies is using NavDx to assess the risk of minimal residual disease. And certainly if you have a path CR coupled with MRD on something like NavDx or for non-HPV, maybe something like Signatera, you're probably going to feel very comfortable omitting RT. I think what we do in practice now is we use the pathologic response coupled with a risk benefit calculus here. I mean, this patient, I don't know what his response was, but Scott's patient, if that patient with a complete pathologic response to a chemo IO regimen, with say he had an in-field failure, I'd be probably pretty hesitant to apply adjuvant re-RT in that situation.
Yes, great. So I think, yeah, so either way, it seems that the chemotherapy, immunotherapy up front, even if he didn't create a response to this patient, if he had, he would have, spared him a second round of radiation. Okay. Should
May
we?
I share one more thing? Sorry to drag this on.
Oh, yeah.
I think the surgery after the neoadjuvant treatment, depending upon the response, isn't only about the response, it's also about the reconstruction. And
Mm.
so what I mean by that is my patient did not have a lower eyelid anymore. He did not have an inferior or he did not have inferior orbital bone. And so to save his eye would have been probably very troublesome for him because he wouldn't be able to close his eye in order to reconstruct the skin defect. And we would have had with an ALT had a harder time. We'd have to use scapula to support his orbit so that his eyes are on the same plane. So those things come into consideration, not just whether you're getting an oncologic resection, but what will the reconstruction result in for the patient. And so I say that maybe to give myself an excuse to not feel bad that I removed his eye, but if I had saved his eye, I don't know how functional it would have been. So we have to take that in consideration as well.
Right.
I was
Thanks for
just
that.
going to say that maybe the more tantalizing question is for Scott's case, if you combine a radiographic assessment, a bunch of biopsies, and some ctDNA assessment, and you find it's all null, omitting the surgery entirely.
Right. Yeah. Okay, so I think that those are great discussion points. We could be here for another hour just on those 2 points. Yeah, let's move on.
Great, thanks everyone. Unfortunately, there wasn't a complete response, far from it. On pathology, 4.5 centimeter SCC involving bone with PNI, and there was carcinoma focally at the posterior soft tissue margin. We undertook a further PPF excision, and invasive SCC was found there as well. There's a 40% treatment-related changes. The lymph nodes in the neck were negative. And so the question now is of adjuvant treatment, and what everyone would do in this case, given that he's had previous radiation.
Yeah. Dr. McBride?
I mean, this is not unsurprisingly, given the history presented, a fairly poor pathologic response. I mean, I think, and the other issue is that you've exhausted a lot of your systemic options. You could always say, all right, well, you know what, the risk of reirradiation are X, Y, and Z. Let's wait for a local recurrence and then treat them systemically. But you've kind of exhausted all the things you would use for systemic therapy. So I think here your hand is forced, and I would, at this point, recommend adjuvant RT. We've sort of already set down the path of a curative intent treatment, and that would be the next option, given, I think, a paucity of systemic options in the event of recurrence. I think you really want to maximize local control here.
Okay. And Dr. Kavi, the next question is for you. Role of NG sequencing here.
Yeah, I think definitely. I mean, I think in this instance, definitely, especially if you are an academic center, I think the first question is, would I give maintenance IO? I think we always like to consider that question. This guy has clearly progressed on neoadjuvant chemotherapy and immunotherapy, not just once, but even twice with pembrolizumab, in which case I probably would not favor maintenance IO. But his risk of recurrence is very high, in which case I would be preliminarily planning, hey, does he have NGS? And if we order NGS here, how can I plan out the future? He would be considered platinum, taxane, immunotherapy, and cetuximab refractory, sort of pan refractory. His standard of care treatment would be something like single agent capecitabine. Response rates are less than 5%. If he happens to have a PIK3CA mutation, there are clinical trials for that. That's about 30% of HPV positive patients. But NGS may reveal options that will guide the next steps, and those are likely to be better than the standard of care.
Perfect. Thank you. Okay. Next slide.
Okay, thank you. So yeah, to summarize, these are the discussion points. I think we've touched on all of them in terms of the utility of chemo IO in a neoadjuvant setting, technical aspects of a reconstruction, and also the indications for reirradiation. Just wondering if anyone had any other points they would like to add for this case.
Thank you so much. I think we're a little over time with this case. I'd like to move on to Dr. Wang's case, and we can leave questions at the end.
Thank you.
I have an interesting case. My fellow can't be here, so I'm going to present this. Patient, 67-year-old male with a history of olfactory neuroblastoma with left neck metastasis diagnosed in 2013, so 12, 13 years ago. Kadish stage D, Dulgarov T4N1. He had a palpable and imaging positive left neck node. So he underwent endoscopic resection and a left neck dissection, followed by chemotherapy and radiation, and completed in 2013. He's been followed annually with serial imaging and endoscopy, has been asymptomatic. He's a professional cellist with the LA Philharmonic, still continued to play. During his routine surveillance MRI of the brain in 2025, so last summer, this is what it looked like. Um, Here we can see the primary site. Looks clean, well healed, no concerns. But then the neck MRI is concerning. He had had some post-operative changes in the left neck that were stable really for 12 years, a small node. But then in this last one, it enlarged, and there were also a couple nodes on the other side. So I'm going to stop here and ask any of the panelists, what would you do next? Any further imaging, biopsy?
Yep, Dr. Kwan?
I think if we're seeing some changes in the neck, then an FNA would be helpful to start. So that would be something to establish whether there's a recurrence or not. And I'm I didn't hear any recent systemic imaging. Has the patient also been getting serial PET scans as well for the routine surveillance, Dr. Wong?
No, it's interesting. I actually had to fight for his post-op, his surveillance MRIs for the last 5 years because his insurance company kept saying after 5 years he doesn't need them anymore. So no, he did not have a PET CT, just the MRI of the brain and the neck.
Gotcha. Yeah, so one other consideration is if we're looking at this, which can happen with olfactory neuroblastoma, where late recurrences, which are often out of field or distant from the local site can happen, I would certainly consider a PET CT, probably a dotatate at this point, given the specificity.
Okay.
Yes, so it leads to the next slide. So dotatate PET, CT, or MRI. Um, just a few things about dotatate PET MRI. SSTR expression is consistent across olfactory neuroblastomas, and it's associated with dotatate uptake. So this is a relatively newer nuclear medicine study. It's not FDG, but using the dotatate, it can be specifically helpful for olfactory neuroblastoma. So we went ahead and got one for him, and it did show bilateral neck disease. And I'm not going to show you the next one, but um, if this showed just bilateral neck disease, 12, 13 years after the initial diagnosis, and it did not light up in the primary site, what would your next recommendation be?
So perhaps we can ask Dr. Cohen, what would you do at this point?
I'm sorry, you said it did not light up?
The primary site did not light up. It lit up in the neck. And I'm not going to show you the next one because there's another pointed section, but say the dotatate PET just showed activity increased in bilateral necks, no place else, 13 years after the initial surgery.
Were the necks radiated as part of the primary
They
treatment?
were, yes, yes.
Yeah, I mean, if the necks are the only site of disease and there's nothing throughout the body, I would do a salvage bilateral neck dissection.
Yes, that was what I was thinking. But I scrolled further down the dotatate PET scan, and there's huge light in the sacrum. So this obviously changed everything. He was totally asymptomatic from this, but with the sacrum being involved, we no longer think that there should be surgery on the table. So what are the treatment options now?
Hmm.
Dr. Akabe, it's no longer a surgeon's case.
I mean, you could be creative here. You're right. I mean, there are multiple ways of using local therapy. This is a late asymptomatic recurrence, not huge volume, but certainly not low volume. Could you be creative in using local radiation to his pelvis along with bilateral neck dissection? I mean, I think you could. I would say that it would be something to really consider in a disease type that has very limited standard of care options, and our options are quite are modest in their efficacy. I think I would biopsy that just to confirm that that is truly olfactory neuroblastoma. I'm amazed he's not symptomatic from it. You can
Yeah.
order NGS. Again, this is how likely is that to yield an option that's going to be therapeutic. 30% of olfactory neuroblastomas happen to have IDH2 mutations, R172X. That, at least from a clinical trial perspective, may be actionable. Although the biology of this one does not seem to fit an IDH2 mutant sinonasal carcinoma, which are usually high Hymes grade and have relatively shorter disease-free interval. Um, Considering that it is dotatate positive, like many olfactory neuroblastomas are, you could use PRRT, which is an extrapolation again from the neuroendocrine tumors of the GI tract and lung. That would be now a radionucleotide targeting somatostatin receptor. I think that's a very reasonable option. There have been case reports, and I say anecdotal experience with the use of VEGF inhibitors also in olfactory neuroblastoma, which would be another consideration. Would I jump to using chemo? I feel a little hard pressed to doing so in a person who's otherwise asymptomatic. So I probably would not opt for chemotherapy, which has very low response rates.
Yeah, thank you. Dr. McBride, any comments?
I actually do agree with Dr. Avi here. I think here you could use a radionuclide therapy. I think you're probably not going to get great local control with that alone in that massive sacral lesion. So I'd probably SBRT that sacral lesion. I think there's a good case to be made for the bilateral neck dissections, SBRT the sacral lesion, and if you have a radionuclide therapy available, use that to control micrometastatic disease. I mean, I think that would be a very appropriate way to handle this case.
Yeah, so I think I just want to say a few words about PRRT because it's relatively new. There's more literature in the GI malignancies, but it has been used. In the literature, there's small case series. So we did send him to talk to the nuclear medicine people, and he heard the indications, risks, and benefits. He also talked to the radiation oncologist. He had his previous radiation at UCLA. And so the upshot was after tumor board discussion, the decision was to actually not do the Lutathera therapy at the time, but he was placed in a pulse-pal clinical trial and got SBRT to the sacrum and 55 gray and 5 fractions of the bilateral neck. So he actually just completed this literally last week. He did very well during the treatment, tolerated very well, very few symptoms. So, we're still ongoing. It's an interesting question, though. We'll do imaging, but if he has disease left in the neck, would it be indicated or a good idea to do a neck dissection, bilateral neck dissection for him?
Yeah.
Dr. Cohen.
I would love to operate on a doubly irradiated neck. That is my Tuesday.
That's your
Yeah,
favorite thing. That's your favorite thing, Mark.
I think it's low likelihood that there'll be persistent disease after those dosage, but if there are, I would give it a go and put vascularized tissue on top if there's any concern about the local area.
Dr.
I probably would
Khan.
I probably would have done it before realistically, but I think it's a conversation after the trial.
Yeah, no, it's interesting because we brought that up in tumor board, how about his neck? And everyone said, oh, he's got, the sacral disease and it was not recommended, but it was a thought, definitely worth considering. Dr. Kwan, would you do anything differently?
Yeah, I think with the systemic disease, these options are probably the most state of the art, and building evidence around these areas, and the availability of dotatate has really changed how we can detect these very small metastatic foci. The other thing I just wanted to comment on is I think it's awesome that you surveillance them beyond the 5 years and all the way to 13 years and out, because, with all these olfactory neuroblastomas, if we continue with the traditional paradigm of 5 years and out, you're probably not capturing most of these recurrences that are going to be pretty late. So I think, that's a pretty great catch on this part.
Well, I'm glad he was so reliable and coming back to see me, and I feel so bad because at 10 years I told him, you're done, you're past the 10-year mark, but I guess we have to keep on following our olfactory neuroblastoma patients even longer.
I think
So
that
that's it for me. Thank you very much.
Thank you, Dr. Wang. I would just add, I think for our fellows, the dotatate scan, it's really been a game changer for olfactory neuroblastoma. in the sense that it picks up very small metastases. It's very sensitive, and it's superior to PET in this because it's in the PET scan, the brain is FDG avid, but in a dotatate scan, you don't have that issue, and you can actually see very small dural metastasis, which is another common site of metastasis for olfactory neuroblastoma. Okay, our next case is Dr.
If there is time, Shirley, could I ask the group what is your interval of surveillance here for an olfactory neuroblastoma? I don't know, Marlene, if you had access, let's say had access to dotatate PET, insurance or
Yes.
insurance not aside, would you have been doing that yearly?
Yeah, I would have. Yeah. I think after annually, I think after about 5 years and he was so rock solid stable, I was seeing him every few months. And after about 5 years, we stretched it out to 6 months. After about 10 years, it was every once a year. So yeah, I guess um, it would be nice now in retrospect to see when that sacral met started.
Okay, Dr. Kwan.
All right, thank you very much. I'm going to kind of hit the salient points of my very straightforward case of nasopharyngeal carcinoma. So this is a 42-year-old gentleman, Asian, and he had a history of his hypertension and history of smoking, no, not current smoker. Presented with left hearing loss, diplopia for 2 weeks, large mass in the nasal pharynx found to be NPC, EBR positive. Here's our scan, so pretty standard appearance of a locally aggressive extensive tumor. And of course, the curveball that starts is liver metastasis biopsy confirmed. And so the initial treatment for this gentleman was induction chemotherapy followed by primary CRT. It was done outside of our institution, so we don't have the exact records. And he had a very good response to it. 2 months after completion, he developed left cranial nerve 6 weakness and right V2 weakness. And he was found to have this on the scan. So my first question is to Dr. McBride. What do you think happened here? Because I don't have the records. And what would be your management strategies that you would recommend to this gentleman at this point?
Well, coming back to it always starts with what was the prior radiation fields. I mean, this is probably a marginal, I mean, by the looks of it, probably a marginal miss here versus giving the outside team more credit. Maybe it's an attempt to spare some of the critical organs at risk, thinking that this is a relatively radiation sensitive tumor. But either way, the tumor is probably underdosed in this area. Now we're 2 months after completion. I mean, no role for additional radiation at this point. So, I would obviously probably restage this individual with a PET CT, and you've already gotten the MRI, and then talk to Neil about what the what the systemic options would best look like here.
Dr. McBride, I know we're running out of time, but I just want to ask a quick question. So if you have a patient who's had a substantial response to chemotherapy, do you go back and radiate all of the previous field, the entire area where the tumor
That,
was? Or do
yeah,
you
that is a
try
great
and
question.
get away from the
That's
brainstem?
a great That is a great question, Dr. Sri. Yes. So this is typically we would at our institution, we've shifted more towards just treating the gross residual disease to 70 gray after a neoadjuvant strategy. That's proven to be just as effective in terms of local regional control. There is some data on that. So that's what we do in practice. So obviously, almost all of our NPCs, this with stage 2, stage 3 for NPCs are getting induction. And so that's a real benefit in terms of reducing the volume, getting the full dose.
It's like Dr. McBride had read my slides, of course, and he decides to kick it over to Dr. Cave. So what are your thoughts in terms of any systemic options for this gentleman at this point?
Yeah, I mean, this guy's in a very difficult circumstance. I'm assuming systemic staging still shows that he has no disease, his liver metastases are gone.
So that actually cleared, yes.
Yeah, okay. I mean, I think the initial approach was very reasonable. I don't think it would have been wrong to give Gemcis toripalimab for initial disease and then consolidate with chemoradiation. But recognizing that he's PD-1 naive, the standard of care option here would be to consider single agent PD-1 inhibitors. There's sort of provocative data, which I think is reasonable, that was published in Lancet earlier this year of Pembro plus bevacizumab, which led to a significant extension, a significant improvement in response rates and an extension of overall survival, which I think is also reasonable to use in a population. The biggest challenge of that, there was an increased rate of nasopharyngeal necrosis, which you'd have to consider here. Nevertheless, if my radiation oncologist said, this is great options, this is a reasonable option to try, either single agent PD-1 or immunotherapy plus a VEGF inhibitor would be a reasonable option here.
Thank you very much. Yeah, very challenging situation at this point. So he does undergo repeat radiation.
Oh my gosh.
Which has completed 7 months at the end of prior treatment. Eesh. And his diplopia resolved and his facial sensation ended up being stable. And he does have a good response. He's got some sinusitis there now. And, of course, this is, the setup for something to come later. So, of course, we start with the calm before the storm in this situation as you hear the story. So this is his repeat scan at 6 months. And then 3 months later. Dr. Wong, do you want to tell me anything interesting about the scans at this point from your observations?
Yeah, the clivus looks like it's the clivus looks like it's kind of not disappearing, but falling apart.
Yeah.
And this looks like a isolated piece of bone that's floating around.
Yeah. I was trying to figure out what that is. It was just like a different view of the scan. I think that's the left parapharyngeal carotid or the clival carotid swimming in necrosis.
Yeah.
So we were pretty concerned about this, as we talked about now. He does start pentoclo based on these findings, and what it looks like on endoscopy, which I didn't show here, is just crusting. There's nothing that looks exposed. It's very hard to tell. You don't really want to tamper with it. He's actually clinically otherwise well, young gentleman who's otherwise pretty healthy. And so he actually does get started on pentoclo and antibiotics based on sinus cultures, and he has clinical improvement, although we said we watch closely or telling him danger signs about any possibility. So 6 months later, he presents the outside ED with left to greater than right-sided epistaxis. It was relatively high volume by report, but it does stop spontaneously, and he's quite stable with only not a significant drop in hemoglobin. So the ER says, hey, he's not bleeding now, so we're going to have him follow up as an outpatient. So I said, please transfer him immediately so we can take a good look. And so what we see here is something quite different. Dr. Cohen, what do you think about these scans at this point in time? This is now a contrast scan.
I think this dude's in big, deep trouble. I think I actually was going to take a step back. Dr. McBride, what would you tell this patient before the re-irradiation, 7 months after the first radiation, their chances of having a complication like this would be? And again, I don't know if there was protons or not. Just seems like this is a crazy story.
I think the risk of ORN or soft tissue necrosis, the combined risk with a re-irradiation that soon after the primary radiation, I probably would have quoted him something north of 50%. I mean, I think you can argue here that, and what I do with, there's not a lot of data for this, but what I do with all of my patients is start them prophylactically on vitamin E and actually boswellia, which is frankincense. There's some data that can help with reduced risk of radiation necrosis. But I mean, I think substantial risk here going in.
Yeah, so I always answer questions by asking the radiation oncologist a question. It looks like there is an issue with that carotid, that left carotid for sure. Yeah.
Yeah, like that. So it's from the read, it's very suggestive of a pseudoaneurysm from the left petrous ICA. So, for me. So the storm continues. Here's the pre-treatment angio. Fortunately, was able to get him here. He did not bleed, and we see this pretty large pseudoaneurysm at that junction that is pretty characteristic. But very fortunate to have some outstanding neuro-IR colleagues who were able to stent this, and he did very well, actually. He has actually not had any bleeding since then. And question to Dr. Su, Dr. Wong, Dr. Cohen, any differences in how you would have managed this in the acute setting, aside from, or what any differences from what we did here?
We probably would, obviously this is a conversation with the neuro IR folks in a
Mhm,
situation where we don't have vascularized coverage, and I'd anticipate that this process will continue despite your best medical efforts. We probably would embolize off the bat.
mhm,
We probably would not put a stent, and that's just sort of our institutional sort of preference for a situation where again the process is going to continue. Did the patient like fail balloon occlusion or something? Was there consideration for that?
Yeah, so he passed it. Yeah.
I'm curious what the other folks think.
Dr. Kwon, can you please go back to the previous MRI?
Yep.
Just go back one slide.
Mhm,
Yeah. So, that carotid, there's a communication between the nasopharynx through where the eustachian tube, cartilaginous eustachian tube had been. So that's all dead. And now you
mhm,
have all the mucus from the upper area digestive tract bathing that carotid artery. And it's probably
mhm,
going to do the same on the other side as well. The bone is going to, start to be exposed, the mucosa is going to die off. And so I think this is a situation where he does need some sort of flap coverage.
mhm,
I would have done exactly what you have done in terms of stenting the patient. I would have also, right off the bat after that, would have, perhaps debrided him. For smaller defects, I've swung nasal septal flaps across. Even if they've been radiated, I've just swung something to cover it. For bigger
mhm.
defects, we put a free flap in there.
Yeah. I know those were definitely considerations down the line. And we can talk a little bit about that as it kind of evolves. So let me go back to this. So continued surveillance. He's been doing okay, improving clinically again. Obviously, he's gotten more and more frail. So there was always kind of the bouncing back and forth of goals of care discussions. And it actually remucosolizes over in this area, as well as is kind of stabilized. And then he has this stent that you can see that's visibly patent. So he's now currently on Pembroke every 3 weeks for maintenance. What is your surveillance protocol to our panelists again in terms of using a combination of imaging, endoscopy, and EBV DNA levels? How do you usually check for these patients, and how often, I guess?
Well, and I think he's pretty recent from his treatment, so he does need follow-up every few months. I think that he like other people have said, he actually I think should have flap coverage sooner rather than later.
Mhm.
But I think combination of endoscopy, maybe imaging every 3 to 6 months, EBV DNA
Mhm.
periodically.
Sounds good.
In general, though, I would say when he's on systemic therapy with Pembro. In general, our approach there would be to do scans. I mean, just for disease status evaluation, 6 to 9 weeks or so. So probably
Mhm.
more frequent than that.
So we were all in talks of doing something prophylactic for him. And then we have some signs of the next storm coming up. So
Oh,
far, clinically great. And then
Oof.
we have this. So what do you guys think now? Back to Dr. McBride and Dr. Akabe in this case.
Obviously, he had some brainstem necrosis, presumably from his twice irradiated brainstem. So I think in this kind of situation, you got a variety of options. Um, you could do hyperbaric oxygen. There's obviously data for bevacizumab, and there's emerging data in the CNS radonc world of, again, boswellia, which is frankincense, which has shown some actually substantial responses, regressions of this of radiation necrosis in CNS tissue. So. I mean, unfortunate finding, but I'd say you've got a triple option there for the radiation necrosis.
are you really
Mhm.
arguing that frankincense would have prevented this, Sean? Like that's where we're going right now?
Mark, don't poo-poo it. There's data out there. It's available on Amazon. I give every patient a flyer. Plus, it helps my stock option with the company.
I don't have much to ask, to state on the systemic side, but I guess my question would be, functionally, how is he doing, Ed? I mean, now with this radiation necrosis.
Well, that's the thing, comes in and out of doing well clinically. He's extraordinarily resilient, as you guys can see. And you'll see some other additional storms coming up as well. And that's why I think, we've always
But
kind of been
neurologically,
thinking,
he's not experiencing any issues from this brainstem involvement now.
no,
Amazing.
yeah, it's a finding on imaging. So, all right. So the next storm comes, continues on Pembro and Pentaclo. Brainstem lesion improves. And then he has this. Okay. And that was about the time when we were trying to talk about doing something, and this gave us pause. So this is actually a pretty, I've never seen it this extensive before. And what is the role? We talk about doing free flaps. We talk about trying local flap coverage with some vascularized tissue. When you guys see something like this, what is your, in retrospect, hindsight's 2020. What is your time frame for intervention? And for something like this expensive, how would you approach it? So again, to Mark, Marilyn, and Shirley.
I just point fingers and ask the radiation oncologist to manage it. No, I don't.
From any of this, Ed? Is he symptomatic?
At this point, when this change started happening, he started having more clinical deterioration. A little bit of mental status changes. Definitely much weaker in and out of the hospital. So his health condition was also not as great either. Poor nutrition.
I mean, unfortunately, this patient needed a goals of care conversation because
Mhm.
you can do a radical resection, and there is data on temporal lobe resection for temporal lobe necrosis and how it helps to reverse the process. You could put a bunch of free flaps on top, but like something else is going to start getting picked off. Like this is not sustainable, and unfortunately, someone has to have a real conversation with this patient to let them know that the end is probably coming sooner rather than later.
Yeah, and I think that's something we've always kind of broached pretty early, given that he presented with M1 disease, and it's just an ongoing thing, especially with you know basically one step up, three steps down consistently. But this is one of those very challenging situations where you're seeing a pretty extensive focus. I mean, it's all the way to the back of the head. So anyways, I think resilience is really the key to this case. He actually improved spontaneously, but now he has another focus in the brain. So it's always like, really, are we going to really do anything to help him with any type of aggressive surgery if this is going to be the case? So I agree, a goals care discussion. He's holding on tight. I still see him. And the one question to end for everybody is, how would you have changed the management if there were no distant mets up front? Or would you have changed it? Any of the panelists?
In terms of the management of the ORN or the soft tissue necrosis, or just the decision to do the radiation so soon
Yeah,
after?
any of the above. I think just some type of guidance going forward for if we see another straightforward case of NPC.
I mean, I would have tried he hadn't seen IO as part of his initial treatment. There is obviously good data for IO and NPC. It's a virally driven malignancy. I would have tried that up front and seen his response to that before committing to basically re-RT.
Yeah, I think I would agree with that. I think his initial approach of induction chemotherapy or conversion chemotherapy, we know the response rates are close to 90% in EBV-associated nasopharyngeal carcinoma. So to do chemoradiation, even in the setting of de novo metastatic disease, not unreasonable at all, and then consolidating with chemoradiation. I really think that the misstep potentially was on the reirradiation side, so close. In that instance, I think I would have also given immunotherapy.
I think, Ed, it's like skull base is such a hard area to radiate. We think about, coming out of head and neck or rhinology fellowship and doing, subspecialty training to do skull base surgery. I think it will be the same for our radiation oncologists. The more common tumors are a little bit easier to treat. In the skull base, there are all these structures. And I think the experience of the radiation oncologist, who you send your patients to, is also very important. And it's really important because you as a surgeon manage a lot of these sequelae.
Mhm.
You can't send them back to the radiation oncologist, unfortunately, at that point.
So I guess here's a question for you guys then. Would you have put on, if the patient didn't have METs to start with, would you have been earlier to jump to some type of tissue coverage for the carotids, or would you have waited first to see that this was an issue?
Look, I think I've been in this situation of patients with meds and they're on systemic therapy and it's very slow progressing. And I know that if I don't put a flap in there, I'm going to be the one being called back, right? Like having another carotid blowout on the other
Mhm.
side, thrombosis carotid, getting into a massive stroke. Um, I think it's pretty reasonably straightforward to put a flap in there. It's just soft tissue, connected to the facial or the temporal tunneling through a caudal lock, and you're there. So just had such a low threshold for putting free flaps in there now.
Well, I appreciate all the input on this. That's the end of my case. And yeah, thank you again, Dr. Sue.
Well, thank you, everybody. Are there any questions? Let's see. Uh, okay. So we're at 7:07. I don't see any questions in the chat. So thank you to our panelists. Thank you, Dr. Barber and JJ, for having us. And looking forward to the next one.
Yeah, thank you all, guys. We'll have our next one the first week of March. And thanks for everybody for joining. A really great discussion. I know I learned something. So thanks, guys. Thanks for being here and have a good night.